But I do really feel passionately about this because I feel passionately about osteopathy. And so I suppose really, although this is about women's health today, and we'll talk a bit specifically about some of the pathologies involved, just as an early sort of primer until the room warms up enough that we can do some practical. Really, I think it's just osteopathy. It's not women's health osteopathy. I think osteopathy has a lot to offer in a wide range of cases. And I know before we get into the slides, I just wanted to think about the process that we go through and perhaps the model that I work from, so that we can kind of see, the direction and think about where our work fits in with that. And it just really solidified for me with a presentation I went to with Christian Fossum. Normally I pinch his slides and put them up here, but I didn't. I thought I had so many already today, and we're not going to get through them all. But I didn't put it up there. But he talks about all osteopathic practice, no matter how you work, whether you are mega bone cruncher and you work in 5-minute appointments, or you take an hour and you sit with the tide and you don't influence it at all other than being there and observing it. You're not trying to create an input. Either way, everyone will work in one of these three areas in terms of all of our work will fit into these sort of areas of work. And he talks about three approaches within osteopathy. He talks about, first of all, symptomatic. And then he talks about minimalist approach. And he talks about the maximalist approach. And I think it's worth... Maximalist, I think that's not right. That's it too close. I've got my glasses on, so I can't actually see what I've written. But, so, if I explain very briefly how these models work, and you'll begin to see, well, that's how I work, or that's how, and you'll begin to see that maybe your thinking has evolved over time. So, if we talk about the symptomatic model, first of all, that really is exactly what it says on the tin. Patients come in, they're acute. Let's say they have an acute knee sprain, they were playing hockey or whatever the day before, they come in, their knees are fused, and they've got an acute problem. In those cases, they're probably not going to take kindly to you working on their earlobe or on their little toe or something like that and saying, well, look, this is going to balance your mechanism. You are, at least at some point, going to test their knee. You're going to try to symptomatically resolve what is going on in their knee so that they feel like they've got a plan in place so that within the next few days walking will become easier. So that's your symptomatic approach. That's how you start, and in those cases where it's really bad, and these are the cases, Monday morning, massive antalgic gait, you're just trying to get the person in some way not worse, so they're actually able to possibly walk out of the room a little straighter than how they came in. So that's an entirely symptomatic approach. But I think all of us realise that that's probably not a long-term approach. That's just, you're trying to get them in the next, you might see them in 2 or 3 days' time, you'll give them advice, all that sort of thing. So that's your symptomatic approach. And then once, in my head always, it's kind of like, well, let's just get this bit out of the way, and then let's see you, once that's all better, then we'll see what's actually going on with your back the rest of the time and why this happened. That's kind of the thinking. So you move from symptomatic to let's find out why this happened, let's see what goes on when your back's not completely spasmed. And then you begin to then analyse posture, and that's where these other two models fit. So the symptomatic approach is really working very localised, it's very acute, it's usually a very simple onset etiology, and while the patient may be very stressed about it, their overall allostatic load, their general life stress doesn't necessarily need to be high for this to have happened. It's just one of those things that takes place. Then you have something called the minimalist approach, which is characterized by high levels of examination and maybe short, focused treatment in a very specific way. So if you take a 30-minute appointment schedule, you might spend, 5 minutes chatting at the beginning, 15 minutes in examination, and perhaps just 7 to 10 minutes of very specific treatments aimed at specific areas of somatic dysfunction within the body. So this has a high level of examination and a low level of treatment. It's very specific treatment, but treatment isn't taking up the bulk of the time. It's really intervening in very specific key ways. I suppose for those who are ESO graduates, if you think historically what would fit in with that model might be the SAT approach, which is where you do a global scan through the body using the unities approach, and then you come up with one area that is most in trouble, you adjust that and then wait for everything else to come aboard. That's one way. There's lots of other ways of working in a minimalist model, but that's one example of it. So what you might come up with a minimalist model is a manipulative prescription. And this is very much the favoured approach of the American osteopaths. They use this. I remember with some sort of amazement reading when I was a student some of the textbooks and sort of a particular a case report of an osteopathic physician working in an ER department and assessing someone with an acute ankle sprain, but then went on to list all of the lesions in the spine. And I thought, how the hell did they do that in 15 to 20 minutes? How did they come up with this list of lesions and then applied over 2 or 3 minutes just a quick few METs, HVTs, BLTs, whatever they wanted to do to the specific manipulative prescription, and then sent them on their way. And and that's sort of another day, another course. Some of you will have come to that sort of stuff. Will know that I talk a lot about MET, and the reason I use MET as a vehicle is because it's not just a treatment, but it's a system of diagnosis as well, because it uses a very quick systematic scan through the spine. We're going to use a version of that today in terms of how we determine where we're going to treat. And so the minimalist model relies a lot on this. You scan the body, you look for the areas of greatest restriction, areas of greatest trouble, and we'll talk about what that might mean as the day goes on. And then you apply very specific treatment to those areas, re-examine, and then treat again if necessary until all of the key lesions have been addressed in the body. If you feel that day, then things are working well. So that's a minimalist approach. And then the maximalist approach is really, these are the patients who come in and they have a list of complaints. As long as you're on, they are unwell, they are systemically unwell. You just think, how the hell am I going to help this person? They just need to go and take a walk every day, they need to lose some weight, they need to just deal with some of the other stresses that are going on in their life. So they have massively high allostatic load. And you just know they're not really going to be hugely responsive, should I say, to a lot of what you do. They just don't respond to the minimalist approach particularly well because they haven't got the available energy to begin to get well. They just, so actually in those cases, then the maximalist approach is what is used, and the approach is one of supporting their physiology, their circulatory system, just trying to get some of the basic underlying physiology functioning better. So these cases can be, well, I'll give you an example. One just very recently we saw in the Women's Health Clinic. So in the ESO. So it's a woman who was medically retired in her 40s because she has an underlying undefined neurological condition which leads her to poor coordination and gait. She has had endometriosis and has had 15 major abdominal surgeries in her life. Her abdomen is really just a checker mark of scarring all over her abdomen. Because of the underlying neurological condition, she can't void her bladder naturally. She has to apply pressure suprapubically to induce enough pressure for the bladder to void. And that's been fine. She manages that every 2 or 3 hours. She'll go and she'll do that and things are fine. And she kind of manages. The reason she came to us is because she's like, well, I can't go 2 or 3 hours now without, I'm now getting overflow incontinence. So she's not voiding her bladder naturally. It's just that it's getting so full and she's not keeping any degree of control. And you listen to the history and you look at the student's face going, what the hell am I supposed to do? What do I do? And interestingly, so this is, am I going to contradict myself here now? I realised that because what we did in the end was like, what do we do to support this woman? So you put your hand on her tummy and it's just rock hard. There's just no give, there's no fluidity there, absolutely nothing. And so what I said to the student, I said, look, just spend a little bit of time, put the heel of your hand suprapubically, apply a little compression and superior traction, because this is where the most tension was within her abdomen. I said, we just need to get some sense of give. We did some work on her diaphragm just to get the diaphragm moving. And I'll show you some diaphragm techniques, because a lot of the ones that I was initially shown when I was a student and I'm sorry to some of the ones who may have taught me those two, but I never found them very effective. I never liked them very much because you're digging up underneath the rib cage. I could never feel anything, so I don't know. I've seen some others, and so I've just copied those, and we'll try those at the end and see what we think. But we just do some work on the diaphragm, just really basic, simple. Let's do some foot pumps. Let's drain the knees, drain the hips. Just work on very, very simple principles of just getting her basic physiology functioning better. And we're what, 3-4 weeks later, and she came in this week, massive smile, saying, "Oh yeah, no accidents at all this week. Everything's fine. It's been much better, and I'm really happy." She still has to manually evacuate her bladder. She's still got all of that stuff going on, but she is now in a better place. She feels much happier, just with some of the basic stuff that we've done. And her abdomen has softened. It's changed. It's quite remarkable, the capacity for the body to do that, despite the fact that there's massive scarring that's taken place because of the surgery. So those cases are actually really nice. They really give an opportunity for us to intervene and make quite significant changes. And you just have to trust your hands to find where's the biggest problem in the body, and let's try and make some change to this. So the maximalist approach is about just trying to support physiology, circulation, get the people well enough that you can then begin to start looking at your L5 FRS or left on left sacral torsion or upslip downslip denominate or whatever, Taylor strain or whatever it is, all the stuff Renzo talks about, all these little lovely lesions all over the body, and there is a way of doing all of that, but the patient's got to be reasonably well to accept that approach. So many of us will swap between these approaches during the day depending on the case, depending on who we're working with. And I found it really helpful when I heard this. I've never heard it put in that way, but in my mind, and you might disagree with this, but in my mind, I saw it that a symptomatic approach is not how you want to continue. You want to kind of bring these people to the point where they're well enough that they can accept a minimalist approach. That they're out of acute pain. With a maximalist patient, you're trying to perhaps move them toward this minimalist, middle ground, where you're trying to get them well enough that they can then accept that input, and you can really start to get down to some of the other nitty-gritty. But until they're well enough, certainly with these patients where they just haven't got that available physiology, it's kind of like moving deck chairs on the Titanic. It's just not going to make a fundamental difference. So I suppose in my mind I aim for this approach, this minimalism and a minimalist approach, because it's just how my practice has developed and what I've found has given reasonable results and given me some degree of security. I spend my life with quite a fragile ego, wanting my patients to get better, so it's quite hard to, and I'm looking for any possible sign that what I've done has made a difference. And so if I can, look at before and after and get some sense, there's a change, okay, I can justify asking this person for money now, and I've made a difference. I spent huge years in my early career searching for ways of trying to verify, that what I was doing was making a difference, and looking for some sense of feedback so I could just say with some degree of conviction that there was going to be a change. And that was just a personal need, and that's what's driven everything that I do, really. And I figure there must be, and one of the reasons I teach now is, because there must be people who felt the same way. It was horrible. I didn't really enjoy it. It was really scary, because I didn't really feel armed with those. We had these, gurus when I was, people who've been in practice forever, and you just kind of, and they just go, oh yes, this is what's going on. And you just think, I don't know what's going on. I can feel it's a bit tight there, but don't ask me what the components are or what goes on or how to fix it, because when I do it, it doesn't seem to have the same results. And so, that is the reality. We spend a lot, and I think if we can create a framework of thinking, and even if all it is just a framework to give us some degree of security while we're working on our own, so that we can make some logical decisions about how we move forward and how we treat. Because then we can actually feel confident in our osteopathy. Because I do think there is something unique about what osteopaths do, because the underlying philosophy. It's not the techniques, because we borrow them from everyone unashamedly. If someone else comes up with a good technique, we'll add it to our arsenal of osteopathy quite happily. We get a bit unhappy when people do the same to us, but maybe we shouldn't, because we do the same. We definitely do that. But there is, the strength of osteopathy is the philosophical reason for you working, and it's this idea that we have something to contribute to health overall. And I really do feel that there is something about that. And what we see commonly in students, certainly now when I've been involved with the FOPI exams, is that this is the final osteopathic practical exam. This is not the CCA, which is more of a safety exam. The FOPI is supposed to be an opportunity for people to really show off their osteopathy. And what you see is that students retreat to where they've got clear security. Well, I know the orthopaedic test for the shoulder, so I can do that. I know the orthopaedic test for the hip or whatever, and they'll come up with all the orthopaedic tests with the evidence and all of that, because that's kind of the approach they get. But then it's like, well, none of those tests, they're designed for doctors or physios or others who are trying to design what we're going to do, whether we do injections, surgery, or drive protocols. They're not useful for osteopaths, other than helping us decide whether we want to send people on for those referral pathways. And what I realised that we're not serving our undergraduates very well is we're not giving the osteopathic same level of rigour to our osteopathic examination, to what we do with our hands. And it's partly driven because it's fashionable at the moment to say that palpation is not a valid form of diagnosis, and there are many who are saying that. And so it's destroyed people's confidence in actually using their hands. But if you think about people where you've been to osteopaths, it's really made a difference, and you just know what is it about that encounter, no matter whether they work structurally or whether they work in a really functional way. There's something about the way their hands connect with you that causes you to go, I trust their hands, I trust that connection, something changes in my body with that hands-on contact. And either what happens with students is, one of the reasons that cranial is very popular is because actually it's a whole system of examination and treatment within it. It gives a protocol for examination and treatment. We haven't really done the same with structural. We haven't done that, and we haven't necessarily done it as well as we could with visceral, and then integrating the three together. And very interesting, I was talking to one of my students this week who transferred from France to here, and she'd done 3 years in France and then doing 2 years here. And she said it's great, she'll come here and she'll get a master's degree, she can practice anywhere in the world, and that's really helpful. But she hasn't really looked at anything osteopathically since being here, and that sort of broke my heart, really. I just thought it was really sad. And I said, and this is probably the most osteopathic institution in the UK at the moment, as far as undergraduate work goes, and that's what's happening. And I think that's sort of quite sad. And I think people in this room could do something about that if we can contribute. I don't know how we do that, but I think we could. I think even if we have to do it postgraduate, and we, I don't know, create some kind of osteopathic finishing school, what you should have learned at college, I don't know. Because there are clearly lots of people who feel that way, and it's not just people who want to work in a cranial way, and they want to work in other ways because that's how their body works and how they interact with patients. And I'm not sure we've done enough in this country to do enough about the osteopathy bit. We're very good at the allied healthcare professional picking up pathology and doing all of that. I don't really worry about our students doing that most of the time. They're pretty good with the differential diagnosis, but patients are coming to us paying money for us to do osteopathy. Not to do physiotherapy, not to be their GP, they come to us for an alternative, and they want us to actually intervene and do what we do. And I'm not sure we're always equipping people with that. And so that's where I come from. Not that I have all the answers with techniques. I just think that actually what we do when we think about how it can work can make a big difference. So, so in terms of women's health, why is there a need? I'm not going to bang on about this too much because I think I showed this once before when I did an evening slide. But basically, we don't examine women well in this country. We don't support women well in our health service here with functional health issues. We're much better at the cancers and so on. We're not brilliant at that still, but we're better. That's where the best care comes. But as far as functional problems, it grows out of personal experience and seeing my now oldest son, when he was born, he's now an osteopath, which makes me enormously proud, but when he was born, I saw my wife, feeling like she was never going to walk normally again because of some of the trauma that happened around delivery, and frankly, there wasn't anyone to turn to for help. Who the hell do we go to? You go to the GP, well, it'll all get better in time, and it was just, there was no one. There was only Renzo. Renzo was the only person who was doing anything, and it was just really, it was quite overwhelming. It was, feeling like someone should be able to be helped here, and no one really examines. There was a sort of cursory 6-week examination, and kind of saying, well, yeah, everything looks okay. And my wife kind of looking, well, it certainly doesn't feel okay, And there was well, no, it'll all be fine. Just that's where we were, and so I just saw firsthand, or secondhand or directly seeing, you know, what that awful experience was like and how difficult it was, and just thought, well, you know, my wife can't be the only person going through this, and you start to ask the questions. And the fact is that, you know, women have almost stopped talking about it, except to each other. I had one patient saying to me, she said, well, you know, it's great to be able to come here, you know, it saves me having to just only talk to my girlfriends about this, you know, the fact that, you know, I can't cough and sneeze without wetting myself, you know, that's kind of this unwritten thing that most men are completely unaware of. They just don't involve themselves with it, they don't think about it, they don't ask about it, but and in practice we should, you know, I often get asked by students, well, who do you want to come to a women's health clinic? And I say, look, if you're treating a woman in her 40s or 50s and you notice that you can see she's wearing a pad and she's not, you know, having periods anymore, there's a reason for that, and you should be asking about that, and you should be saying there's something that you can do about that, because the chances are there's some degree of stress incontinence there. It's this unwritten, it's unspoken thing. It's never talked about. It's just ignored. We just pretend it's not happening because, well, I don't know what to do about that. So, but you can. There's a lot that we can offer. So, we don't examine women well. But many of these functional problems, they do respond well. And, you know, the pelvic contents are mostly soft tissue, and that's kind of where we, you know, our realm, that's where we can intervene. And so we can do that. And Claudia asked me 3 years ago, possibly it was, that she said, well, do you fancy, I was back as a clinic tutor, and then she said, look, do you want to try setting up this sort of specialist women's health clinic? I thought, oh, yeah, great, that'd be good. It's nice, ego massage stuff. Great, we'll do it. And then I suddenly thought, the reality is, how the hell, you know, it's not talked about anywhere else on the curriculum. What are we going to do in 6 weeks? I have these students to, you know, bring to a point where I'm not having to do all the treatment, you know, that they can do that. And so we came up by this sort of by accident, combination of what Renzo does, combination of what Richard Twining does, combination of anything I could read in a book, anything, you know, I was just looking for it and just going to go, okay, what do I do? So the protocol we're going to look at is what I've developed for the Women's Health Clinic. It's by no means the only answer. It's a student project where I was asked by one of our 40ers 3 years ago. She specifically wanted to look at the Baral approach, whether it could have an impact on dysmenorrhea. So we went through all of his books, came up with all of the steps, all of the protocols, and included them then in a sort of spreadsheet and said, okay, this is what we're going to do, and just try examining everything according to this protocol and treat what we find, and then just see, does it make any difference? And it did. We got about 60%, 65% improvement in dysmenorrhea symptoms, quite marked improvement. And it made me realise there is a value in protocols, even though we're sort of fight against them a little bit as osteopaths. And it was horrible because I couldn't do my usual examination. I just had to go by what was said. I thought, oh, I want to do that. No, you must stick to the protocol. So that sort of was the germ of it, and then we developed the idea from there. So and setting up the patient education, getting patients is really problematic. And well, osteopaths don't deal with stress incontinence or pelvic pain or, you know, prolapse or all of these other things, you know. And so it's educating the students so they then learn how to talk to patients. And we're not there yet, but what we've done is we've shifted it from a Thursday evening to a Wednesday afternoon. So I'm in clinic with the children's clinic tutors and the maternity clinic, and so we're now getting a lot of maternity patients, and where I think, and what's great about that is that we can then see them postnatally and start to intervene in really significant ways. So hopefully we can, for those women, prevent the problems that could have happened in their 40s, 50s and 60s, which is how long these things take to develop. You know, it's you know, the gift that keeps giving, you know, years later. So if we can intervene earlier, that's going to be a good thing. So I'm going to talk about some of the models. This all comes from the benchmarks. This is the cover to the World Health Organization report on osteopathy. It's 35 pages. You can download it for free. If you just look it up, it has the benchmarks for osteopathic education. It's a really good document. And from that, it talks about the osteopathic models, the 5 models. Hopefully we're kind of there with that. So there's the biomechanical one, which we're all sort of very familiar with, and what I think college mostly talks about. You know, the respiratory circulatory model, which we talk about, but I'm not sure how often we really think about that in our approach. The neurological model, biopsychosocial, which of course is very important, has always been part of osteopathy, and the bioenergetic model, this idea of efficiency. The body will always find the most efficient way of doing things. So biomechanical we're not going to talk so much about. We will talk a bit about, but we will talk a lot about this respiratory circulatory model, because I think that's really important in the way we approach women's health. It has a big impact. It's why what we do works, I think. We'll see. So, what are some of the common things that we can see in terms of where we can intervene? So these are questions that you can ask your patients. So, all of these areas, the things that we may be able to do something about. I'm going to talk a little bit about some of these conditions that are more common pathologies, just so that it's a very brief primer, and you can go away and read much more about it and know more. So, this I put in again as a primer. These are some of the questions you can ask. So if you download this, it's really useful. It's got the history questions, and then it's got this sort of what it could be. There's a key, so that you can think about the differential diagnosis, and then it's got the key down at the bottom of that. So I'm not going to go through that, but it's just so that you can get a sense of what your case history questions should be and what the answers may mean. That can be quite helpful. So we look at some of the conditions that we see coming in. So we talk about primary dysmenorrhea, first of all. So this is the idea of women who have always had period pain right from their first period, and it's always been a part of their life. It's not really well understood why this happens, other than it may be linked to the prostaglandin effects, but I was talking to Claudia about this. This is entirely her thinking, but I really loved it. It was very elegant in the way that she gave this lovely explanation to students. Early pain versus late pain in a period. So early pain, so if it's right, premenstrually, the day before, premenstrually and the day at the beginning of the period, is often linked to congestive type issues. So that can be the prostaglandins building up more than would be normal. I mean, there could be other sensitivities involved. But she would see that as a congestive type problem. So in these cases, you want to improve drainage, specifically from the pelvis. But you get another type of dysmenorrhea, which can come toward the end of the period, where often there'll be old blood, and it will be a sort of, the first few days will be okay, and then there's this sense of cramping and really quite marked discomfort toward the end. And she sees this more as tension around the cervix, causing it not to dilate properly, and so you don't get good drainage of menstrual blood, and that's why you get the old blood coming. So that requires more direct intervention around the cervix, and there are some ways that you can do that externally. It's much easier to do internally, but it can be done externally as well. There are ways around that. So it's a different thing. So one is a drainage issue, one is more of a mechanical tension, spasm, contractile issue. So I thought that was quite a useful way of thinking about dividing these cases, so you can think about how you begin to manage that. Secondary dysmenorrhea just means it's caused by something else. The most common of these is endometriosis, fibroids, pelvic inflammatory disease, adenomyosis. Adenomyosis is just a form of endometriosis, effectively, where, well, actually I've got a slide on it, so we'll talk about that later. And intrauterine disease, device. IUD can be another cause of dysmenorrhea, although often it can be given, ironically, as a treatment for dysmenorrhea as well. It can be very effective for that. So there are other causes for it as well, but those are the most common. So endometriosis is so that we can talk about this. This is just where there's lining, uterine lining cells, which end up in places that are inappropriate, away from the endometrium. They can end up around the ovaries, fallopian tubes. They can end up in the abdomen. They can even end up in the brain. It's not clearly understood how these things. I know there was this idea that it was retrograde bleeding might be causing it. So i.e. that there's bleeding, instead of draining through the cervix, it ends up coming out through the fallopian tubes and out into the abdominal cavity that way. But then they did studies to show that some 80% of women have retrograde bleeding, so it's unlikely to be the cause. So it could be autoimmune. We just don't know. We don't know. So can we intervene in these cases? I think we can. I mean, obviously you can't remove the lesions. You can't change the fact that these cells are there. But it's surprising how many cases will respond to specific work within the abdomen. And you just test in just the same way as you would in the spine. You just simply mobility test these structures, see what moves, and if it doesn't move, get it to move, and you see an improvement in these symptoms. So you're not treating the endometriosis, you're treating the woman who then happens to feel better and still be living with the endometriosis. But obviously, in many cases, then surgery is the only option. But we may have something to offer. So adenomyosis is much the same in a way. It's a similar pathology in the sense that these endometrial cells end up within the muscle of the uterus instead. So they're where they shouldn't be. So in that sense, it's like endometriosis. We had a very interesting case with this a couple of years ago, maybe 18 months ago, a case where this woman had 5 years of really horrible period pain, awful pain. She'd be coming to the ESO anyway for back pain and other things, and was getting on quite happily, and she was referred to the women's health clinic, and we assessed her and her what was happening. I mean, she's a young woman, maybe early 30s, and her periods were lasting 2 weeks, but the first part of her period was always very old blood discharge, and then she would have the new blood for the second half of her period. She had terrible period pain, she was trying to conceive and all of that. So it was it was all just very unpleasant and difficult for her. And so we just started treating her, saying, I didn't quite say I've got a cure that can help you, but words to that effect. So we're going to try and see what we do. And she was amazing. I mean, she still has adenomyosis, but her periods went to 5 days instead of 14 days. Within 1 or 2 cycles. I mean, it was really extraordinary how much changed. The pain was 0. She just didn't have any pain anymore, and she just felt completely different. And it was really remarkable. And it was remarkable for me because I didn't know whether we were going to be able to help. Because, obviously, the college provides an opportunity to attract patients that you wouldn't necessarily get in practice on your own, because people hear about it, and students are out there saying, "Oh, you could try," and they, students get a disproportionate view about what you can do. So they'll say, "Oh yeah, that's it, fine. You'll be able to get that." I don't know. Thanks for that. And so it's really extraordinary. So she still has adenomyosis. It's not gone away. The diagnosis still stands, but the way it presents and the way her life is very different as a result. And the techniques I'll show you, they're very simple. There's nothing difficult about anything that we did to treat her. Fibroids. Very common, and this just shows you the different kinds that you can get, whether they're within the wall, whether they're external, whether they're pedunculated, all of this kind of thing. And you will just, if your patient has enough of them, is that you will just be able to palpate the uterus suprapubically, which you normally wouldn't be able to do. You'll feel it, it'll be a mass, it will worry you, and quite rightly, if they don't say, "Oh, I've got fibroids," and you say, "Oh, I'll take you to see your GP." So one of the key things with women's health issues is that they should always be medically referred until and be assessed, because so many of these things can be very serious and can be masking as something else. And so anytime a woman has a significant change in her periods, she has an unexplained dyspareunia, she has recurrent UTIs, all these sort of things, and she's not getting medically assessed first, then we need to make sure that happens. And then once they've had those tests done, and they've just said it's this or this, and there's nothing else they can do, that's when we can begin to intervene. And I think that's really important, that we don't jump in too soon, because we don't have the diagnostic. We can't diagnose these cases, so we must always be prepared to send people off to get the diagnosis, and then we can begin to intervene based on that. So some of the symptoms, I think, is quite important. Heavy bleeding is really associated with periods. It's very common with fibroids, and probably the main reason for women, one of the common reasons for women having hysterectomies is because they may be having a period for 3 weeks out of 4, and they're very heavy periods and really difficult, and they can't leave home, and it's all just just really difficult. So that's number one marker. They can increase urinary frequency, and just think it's just mechanics. So you've got a big lump that's pushing on your bladder, so they can cause constipation, abdominal pain, low back pain. Sex can be uncomfortable. So that's why we must always get an understanding of what's causing the problem, and then we have a way of beginning to think about how we can intervene. Stress incontinence. So we're going to look a little bit in more detail at the anatomy, but basically this is failure of the external urethral sphincter. There's weakening damage to it, and you also then have urge incontinence as well, which is slightly different, where you get a mix. So the common types are stress, which is just going on a trampoline or coughing, sneezing, and you get a little bit of leakage. If you have then urge incontinence is that kind of thing. I've got to get to the loo, and I've got to get to the loo now, because if I don't make it now, I'm going to have an accident. So that's your urge incontinence, and then you can get mixed, which is the two, and they all have slightly. Well, ultimately, they all rely on the external urethral sphincter to function well. And we'll look at that and how we might be able to intervene. Okay. Pelvic organ prolapse. Really common, comes later in life, and so we think about why does it occur? Why does it occur? Yeah, okay, it can occur in younger women. Certainly the biggest risk factor for that is childbirth, but it often happens later. Even though the trauma happened many years before, it occurs in women in their late 40s, early 50s, and 60s as well. What do you think the mechanism behind that might be? Why? I'm hearing sort of muscles or something.
Like where they haven't got the pullback of elastin and the pressure.
So why is that occurring? You're right, yes, that is right. But why is that happening? Why is a 50 or 60-year-old more likely to have issues with elastin and loss of elastic support?
Diminishment of estrogen?
Yeah, that's the key. It's estrogen, it's loss of estrogen. So it may surprise you that I'm actually quite, as a bloke, it's easy for me to say this, I hate that, but I'm quite in favour of women looking at the option of HRT, because there are estrogen receptors all over the body, and for women who go through the menopause, they just drop off a cliff face in terms of estrogen levels, and so for some women, only 1 in 4 women, 1 in 5 women, between 1 in 4, 1 in 5 women have no symptoms at all, which means everybody else does. And they average 7 years of symptoms around menopause, and over 10% of those will last for more than 10 years. So it's really quite a huge. No man would put up with that, I can assure you. I would not put up knowing if there was something that could be done about feeling like crap for 7 years, and and just taking some form of medication might change it. I can guarantee most men would. I certainly
Can I ask you something here?
Yes.
What about the cancer risk factors?
Yeah, no, that's absolutely right. Well, again, talking to Claudia about this, I said, look, I've read about it, so there are a number of cancer risk fears about that, so we'll talk about that because it's very topical. So, breast cancer is the number one worry around it, and the studies that have been done about this, really, I think we just need to talk about risk, because basically, I think for the general population of women who are postmenopausal, their risk of getting breast cancer is something like 23 cases in 1,000, 23 women in 1,000 will get a case. It's not really cleanly very well, so I'll just give you the numbers right now. So 23 in 1,000. If you go on to HRT, that goes up to 27 in 1,000. But if you set that in context, if you're overweight, your BMI is above 30, your risk goes to 46 out of 1,000. So compared to being overweight, HRT has relatively minimal effects. One of the reasons why bioidentic hormones might be an answer, it's not nearly as expensive as I thought. I was talking to Claudia again about it. She's a reservoir hormone. You should have her come and talk. She's really good, knows a lot about this sort of hormonal stuff, much more detail than I do on this. But she said one of the reasons that bioidentic can be helpful, it's not the estrogen that's the issue. The estrogen in HRT, NHS HRT is fine. It's the progesterone, or what they use in substitute for progesterone. And if you have bioidentic, then your risk is almost zero. So frankly, you can just go on that and it doesn't have a risk. It's the progesterone. That seems to be where the research is around. It's the progesterone that's the problem. Now, if you've had a hysterectomy, you can just have estrogen on its own, and therefore there's no risk you take it to the day you die. Because as well as the fact that yes, you may have a slightly higher risk of breast cancer, but the risk is relatively small But your risk of heart disease goes down, your risk of bone density issues, all of the risks around falls and fractures and so on massively decreases on HRT. So the estrogen's not the problem. You don't need the bioidentic estrogen, but it's the progesterone that's used in the HRT preparations which may be the issue. But you can't, if you've got a uterus still, you can't have just estrogen on its own because you'll get thickening of the lining and you've got a high risk of cancer. So you have to have the progesterone to balance the risk of having estrogen as a supplement. So, but estrogen is really key, and when the estrogen goes, suddenly the support structures, the elasticity of all the structures changes hugely within the all over the body, but particularly within the to vulnerable structures in the pelvis. So, pelvic organ prolapse is graded from 1 to 4. 1 is just a little bit of drop. So if you imagine. This is healthy. 1 is about half, it'll drop about halfway, so if we take the uterus particularly, it'll drop halfway down the vaginal canal. If it comes to the entrance of the vaginal canal but is not external, then that is grade 2. Once it becomes external, it's grade 3, and once it's completely evacuated, which is possible, that can happen, that's a grade 4. And we can see another picture there showing the grading, and another one here. So just so that we can kind of picture that scale. Yeah, I mean, it's not great, is it really? So anything you do to prevent that's got to be a good thing. So can we intervene? Obviously, structural damage has happened in these cases, but there still can be, somewhat particularly on grade 1 and mild grade 2 cases, we may be able to have some effect. We're not going to literally reverse the grading, but we can make a difference. And certainly help when patients have gone for surgery afterwards, we can then begin to intervene post-surgically as well. Okay, so if we then look at, we'll look at some of the normal anatomy and physiology, just try and just get these, a picture. I won't spend ages on these things. I'm going to let that off. That shouldn't be in there, that slide should be somewhere else. I obviously dragged and dropped it. So if we just look at first of all the osseous anatomy and just think about how this functions, we have the sacrum, the ilium, and then the lumbar spine. We don't talk much about that, but what I really just want to emphasize here is the role of these ligamentous structures. If we have this pivot around S2, that's the pivot around which counter nutation takes place in the sacrum, and that is stopped. Naturally, if left to its own devices, the sacrum would just mutate. It would just because of the weight of the body on there. So there isn't an active process stopping that. It's actually passively stopped because it would be enormously hard work to make an active process. So these posterior sacroiliac ligaments play a role because they sit above this pivot, and below the pivot you have the sacrospinous and sacrotuberous ligaments. And those ligaments are really important, particularly sacrospinous, sacrotuberous ligaments. They're really useful that we can palpate those, we can understand where they are, and because they run particularly close to the pudendal nerve, which is can be quite a source for perineal pain. So that's just a revision of the anatomy, just so we got an understanding of what's going on. If we start to layer up a little bit, we start to add some of the ligaments. One of the other things we're going to look at today is the obturator membrane. So as osteopaths, we obsess a lot about piriformis, particularly because of its attachment. It's the only muscle that attaches to the anterior face of the sacrum. It's an external rotator of the hip. So we all obsess about that, but we should be as obsessed, if not more obsessed, with obturator internus and externus, because they are both external rotators of the hip, and they are very closely linked to the bladder. If you think about the bladder anatomy, the bladder sits immediately behind the pubis here, and obturator is very closely linked. So obturator is highly linked to function of the hip, and so ultimately, with bladder problems, we always have to look at the hip and how we treat the hip, how we assess the hip, and we're going to talk about that today. And we look at levator ani, we've got this varia and coccygeus, these muscles here, which form this basket, this support basket, but there is a large sort of hole anteriorly in front of the anus where the levator ani doesn't come as far as that, and that's filled in by the transverse perineal membrane. But this muscular structure of levator ani, it runs often in a sling type, so the fibers go posteriorly around these structures and then come back again. So they have the effect of pulling stuff anteriorly as well as superiorly. And of the muscles which can cause issues here. The other interesting point about levator ani is that it attaches directly to the fascia of obturator internus. So it's one of the few muscles that genuinely attaches to another muscle. And so that again means that when obturator is hypertonic, it's going to have an effect on levator ani, which in turn is going to have an effect on the support and drainage from all of these pelvic organs. So it's very important to be able to address, because it's really quite difficult to get to levator ani. It's actually quite deep. You know, if you think about sort of the techniques that you may have learned and we'll look at today, working on the issiorectal fossa, but it's a long way up there. There's a lot of fats that you're pushing up into. Whereas if you work on the obturator membrane, when you palpate the obturator membrane, you feel generally just the inferior half of it. And if you then palpate halfway up, you'll find a thick tendinous structure that runs across the obturator membrane, and that is the insertion for levator ani. So you have an ability to begin to influence levator ani directly by applying pressure and techniques that modify obturator. So when we think we're doing MET to piriformis, in fact we're probably just doing MET to obturator as well, or we are. It's not what we think we are. We definitely are. It's not just piriformis. Okay, yes, so we come here, again, filling in a bit more of the structures. So now we can see on this lateral wall here, again, usually pre-birth, we're going to do, is it easier for me to stand over there? That'd be better. I feel like that's my natural science. Okay, so we have the ovaries sitting more on the lateral wall, sitting in this little nook between the arteries where the internal iliac artery splits, comes externally and then runs down inside the pelvis. The ovary will sit back in that. The ovary also, right, some of my fourth years who are in my lecture this week, what else does it sit? What sits just posterior to the ovary? You remember? Well, you have not had that lecture yet. Maybe I... No, you have. You've had this lecture. You should know. Okay, I'll put it on top. Obturator nerve sits directly behind the ovary. And so one of the things that, you know, those of you who treat children, you might think, you know, you get girls who are sort of pubescent, just coming in developing cyclical knee pain. You think, what the hell's going on? And it's usually mid-cycle, so it's before, you know, around at the time of ovulation. And so you think these ovaries, which have not been giving off eggs at all for the first 11 years of life, or however long, they're now suddenly coming into activity. There's mobility and motility now in those ovaries, and so they are going to have an effect on the structures immediately around them, particularly obturator nerve, because it's very closely, it's tied up within the fascia there. And so if you get this sort of random knee pain that seems to be mid-cycle, think about the fact that that's influencing, you know, if we don't, you check the knee and you find there's nothing wrong, so you think, oh, well, it's the pelvis. Well, maybe it's not the pelvis, it may in fact be the ovaries that are causing the issue, and it's sort of around ovulation. It's pressure on the obturator nerve. So it's those kind of anatomical links that we want to try and think about how, you know, when these physiological processes are happening. So we can see the ovary, we'll look at that in more detail a bit. What you can see here is the cut edge of the peritoneum, very nicely here. So we see the bladder sitting immediately behind the pubis, and then we see this fascia, connective tissue, peritoneum, which sits in, and we form these two pouches, the pouch between the vesicouterine pouch here, between the uterus and the bladder, and then we come into the rectouterine pouch. I never name it like things I can never remember which one's pouch of Douglas and whatever, because it's useless. It doesn't tell you what it is. So let's just go for describe. I'm all for naming things what they are. So the rectouterine pouch here. This comes a long way down, and it's a really common site for endometrial tissue to end up in this rectouterine pouch. It's a very common area, and it is an area that if you work internally, you can get access to, because it's right at the posterior fornix of the vagina, so you can actually reach into that rectouterine pouch there. You can work or directly influence, and you get a sense of working on the tissues here, if there's huge amounts of congestion and so on there, which can occur. So, and you see this peritoneum is continuous with the abdominal wall. It runs up anteriorly, it runs up posteriorly, it runs up laterally. It's all part of the same structure, but they all get named different things, and we're going to look at the broad ligament, which is just peritoneum. it'd be much easier just to think of it as that.
Sorry, would you mind showing here as well? It's just when you...
Yeah, okay, sorry, yes, so
So
here we have this vesicouterine pouch here, and then you can see this is continuous with the lateral fascia of the pelvis. It comes down over the top, and we've got a very deep, you can see this comes a long way down, and you can see, if you were to palpate at the posterior vaginal fornix here, you can just get access to the rectouterine pouch here, and this is a very common source for where the endometrial tissue can end up endometriosis, so it's a very, very common area. And you can imagine then that the irritation, inflammation that it causes on the bowel, also it's a common area for fistulas to form as well from traumatic delivery. But what I really want us to get the impression of is how, particularly here, again looking at the bowel here, how it's the same. If you can mobilize the bowel, which we can get hold of the sigmoid and we can mobilize that, that indirectly is going to work on this connective tissue, this peritoneum, so that it's going to affect what happens with the body of the uterus and also with the fallopian tubes as they come out laterally. So we can see here, again, just looking anteriorly, that we've got this little membrane here which sits in front of the perineal body. So the anterior portion of the pelvic floor, if ever you palpate this area, if you're just going along the ischiotuberosities and you go medially, you try and go up towards the pubis, just on this lateral margin, you'll find you can't really feel very much because it's really dense, hard tissue. And it's because there's this really thick layer of fascia, which you don't have posteriorly. Posteriorly, you can get into that space and we can work and have an influence on the beta ani. But anteriorly here, this fascia is really thickened and there's muscular striated tissue in there which forms the external urethral orifice. It's also a supportive structure for the vagina as well. So you can't palpate much of this anterior triangle, if you like, externally because of the nature of the tissue. It's very thickened. So that's why we need to directly influence this structure. Often we either need to work from the abdomen, trying to lift, or we need to work internally directly. So that sort of builds up our anatomical picture, and if we contrast that with male anatomy, is that we just simply have this vesico-rectal fossa here. It's much lower. We obviously have the prostate. We still have this anterior diaphragm, fascial diaphragm, which doesn't show very well in this picture. Well, that's what it does, yeah, it's this perineal membrane here. And so Frank Willard's joke about the difference between men and women, he said it's amazing that men can ever pee after the age of 50 because they're getting a whacking great prostate, which is getting larger and larger and blocking everything off. And and also because the urethra in men on average is 22 to 25 centimeters. For women, it's 4 to 5 centimeters long. So mechanically, and so he says his joke is it's amazing men can ever pee, and it's amazing that women still have any element of control after the age of 50. Likely, it's not designed to do that. So there are some contrasts and differences, and you can see there's just less potential for congestion here. But many of the techniques which we'll look at for the uterus can be applied to men as well. One of the other areas which I have, since doing the women's health course with Renzo, I've treated as many men for prostate issues as I have for women's health issues. Chronic prostatitis is one of the medical mysteries which sort of falls under the umbrella term of chronic pelvic pain now, and it's obviously there are a few cases where it's infected and it responds to antibiotics, but there are many, many cases that don't. And men don't talk about it very often because it's kind of embarrassing, because one of the main symptoms, quite apart from the fact that there's an underlying pain a lot of the time, not dissimilar to cystitis type pain, so it hurts to pee quite often, but also ejaculation, at that point it's supposed to be quite enjoyable, it hurts. So rather takes the shine off things, and can and it happens. It affects a lot of younger men as well. So we can intervene in those cases. We can make a difference, and there's obviously a lot of psychological factors around those as well. They're complex. It's not just for osteopaths to intervene, but we do have something to offer as well. So it's just food for thought. So again, if we're looking here, just looking at the anatomy here, I just want us to get an idea where the pubis is in each case, and we have this inguinal ligament here. It's at a slightly different angle in the female pelvis versus the male pelvis. But in the female pelvis, the reason what I want us to really understand is that one of the key ligaments of the uterus, the round ligament, comes anteriorly and forwards into the inguinal canal and then drops down onto the anterior surface of the pubis and into the labia majora. So that's this insertion point. So when you feel in a woman she has a tender anterior pubis, instead of thinking that's the pubis, it often can be the round ligament that is congested. Especially during pregnancy, we often think, oh, it's SPD, but in fact it may, if you trace up, there'll be discomfort along the inguinal ligament there. And obviously there's a difference. For men, they'll have had to descend, the testes will have had to descend, so that creates this inherent weakness, whereas for women, prolapse is, not prolapse, hernia, yes. It's very uncommon for women because they haven't got this weakness there. But one of the differences is that they do have this round ligament which comes forward there. So fascial organisation. This is just, we're not going to go through it, but just basically, Richard's. Here's a pinch from Richard. He's quite happy to do that. He pinched them from the other. Not the slide, but he pinched pictures from the other. So we just look at the fascia quickly. So if we look at it now here, which has been prepared, we start to take the skin off, and when you remove the skin, you see there's a fatty layer immediately below that. This is a firm adherence between the fat and the skin, which tells us that when we move skin, we move that fatty layer. We can't separate them. We can only separate them when we dissect. So if you then remove the skin completely, you're then left with this fatty layer. Sorry, you want me over here. You're left with this constant fatty layer, and you can see that this layer doesn't differentiate between abdomen, shoulder, upper extremity, neck, head. It's all just one continuous structure. It's not differentiated. And that's quite important because it means that if you have a problem lower down, that's going to create potentially knock-on effects elsewhere in the body. If we begin to see this, and we'll take this a little further. So here, we're separating then this superficial fascia from the deep fascia, and this picture is really remarkable where it's the entire superficial fascia of the body has been removed, almost like a wetsuit, and you can see here that it's continuous. So there's nothing. It's just literally just removed the whole out of this fascial layer, and so I just wanted to sort of do a little thought experiment that when someone has abdominal surgery and we create a cut here, well, let's think about it more. Think about a wetsuit. Who here has worn a wetsuit at some point? Yeah, okay, so we've got quite, okay. We all know that wetsuits really only work once you get in the water. On land, they're not much fun. You try and move, the whole thing's very restrictive. So if you imagine that, I'm a real surfer dude, I go down regularly, but because, on the south coast it's very cold, so I wear my wetsuit all the time, and I'm clambering on and off my surfboard regularly, in my head, but, just imagine that's happening regularly, and I wear my wetsuit out here, and because, I'm a bit cheap and all that, I just think, well, and a bloke, I can fix it with gaffer tape, because gaffer tape fixes everything, and, if it doesn't, it means you're not using enough of it, so you just need to use more. So you basically put the gaffer tape across the gap here, and you can then imagine when I'm then trying to swim out and catch my waves, I suddenly notice that when I try and lift my arm here, I can't move it as much because I've got this flipping gaffer tape here, which has got no give. And so I'm relying on the elasticity here, but I can't rely on the elasticity of the whole suit because it's been artificially, there's tension created here. So you imagine that, again, obviously fascia is much, much more sophisticated than a wetsuit. It has healing properties, it doesn't require gaffer tape. But it does have, it is capable of scarring, and that scarring does create a hardening within the tissues and has the potential to impact more globally. I remember the first time I saw Baral's test on, he uses this, what they call relieving tests, or aggravating relieving tests, and he looks at the example of, say, the shoulder. And so he says, we test the shoulder in external rotation, and he says, you have a patient who comes in and you do the test, and they can't take their hand into external rotation with abduction, they stop here. And he said, how do you know if it's a problem in the shoulder or if it's a problem coming from the abdomen? Well, when I was a student, it wouldn't have occurred to me that it was possible that it would be coming from the abdomen. He would have just said, well, of course, there's a shoulder problem here, and it's some kind of rotator cuff injury. And then he then proceeds to say, okay. So he lies the patient down, puts his hand on their tummy, and then proceeds to do this test, and suddenly they have a full range of movement in their arm. And it just looks like magic, and we think, well, how the hell is he doing that? What's the purpose? What's the mechanism? And, he didn't have an answer. He just said, well, it just is, it comes up. Just what it is, it's a leaf, and, he wouldn't... Well, he may explain it, but I didn't get it. So, but when you look at it here, you begin to see that there's a possibility this might be part of that mechanism, this reflex mechanism that is happening through this superficial fascia can be a mechanical transmitter. Now the fact is it's not capable of heavy contraction. It, by definition, it's not well defined, so it's not got contractile tissue. You've got to be careful not to get too carried away, but it does transmit messages. It's nervously, it's heavily innervated, and I'm sure has the capability of influencing other structures locally via reflexes and other things. So it's interesting just to see how these connections work, and just the role the fascia has. And the fascia superficially very much marks what's going on deeper. And if you think as an osteopath regularly, if you're experienced, you put your hands on almost motive, so put your hands on the shoulder, you go, lot of trouble going on here, isn't there? You all do this, but you don't even question it after a while. And so how is it you're able to make that decision almost instantaneously that you put your hands on? You watch someone who's really been doing this a long time and they put their hands on and very quickly, yes, they'll go through the discipline of looking elsewhere, but often they can tell very quickly what's going on. Is it just magic? Is it in the ether? Is it fields? Well, it could be any of those things, but it also could just be the fascia is transmitting, the superficial fascia, which is what you're coming in contact with when you put pressure on the skin, is actually transmitting what's going on a deeper level. So the superficial fascia, you will feel this tension within the superficial fascia, and that's displaying dysfunctions deeper. And you'll see this in a bit. So we can see this honeycomb effect of this superficial fascia, and if you want to get an understanding of how it is, it's very much like breast tissue, the adipose tissue, breast tissue, female breast tissue. When we remove this layer, then we're left with this deep layer. So this is the cadaver afterwards, and very interestingly, once you've removed the superficial fascia, it's much harder, it's obviously possible, but it's much harder, particularly when the patient is prone like this, to tell whether it's a male or female cadaver. It's also in a supine position. If you don't view the pelvis, it's much harder to see, because much of what defines the genders is held in the superficial fascia. And when that's removed, obviously there are some bony changes, but not as dramatic for many as for some. So I just think that's interesting. This is a slide taken from. Anyway, it's a lovely book on. I can't think what it's. Carlo Stecco, Italian anatomist, and this picture just shows a really interesting phenomenon that when we go down through the body, we have. I do need to try and draw a picture here of some sort. I don't draw well, but it might. Well, we use this same idea here, okay, because it actually comes together. Superficial fascia is really composed of skin, fat. There's a layer, very thin layer of superficial fascia. Then there's another layer of fat, and then you come to the deep fascia. So in that case, where we saw the superficial fascia removed, what that was fat. There's a layer, a thin layer of fascia, then a deep layer of fat, and then below that we're seeing this picture here, which is the deep fascia. Okay? So what you'll find though is you'll notice if you have very obese patients, you can still feel their spinous processes. You can still feel their ASISs. You can still feel the iliac crests. Why is that? Even when they're enormous, you will still find that. You'll find folds in their body. And what Stecco has done is she's discovered that there are points in the body where the superficial fascia and the deep fascia meet. And you don't have any adipose tissue. You can't lay down adipose tissue in those zones. It's incredibly helpful for osteopaths because these are all areas we want to palpate. So the reason you can feel the spine is because that's where these layers come together. It's one of the explanations. Over the pelvis, the gluteal folds. So these compartmentalize. So again, these are really good areas to palpate because when you would contact the superficial fascia, you are contacting the deep fascia as well because they're linked mechanically. So you're getting an input as to what's going on a deeper level. And this may give us some clue as to how we're able to palpate in the way that we do while we pick up this deeper information. So there's much more structure to this deeper fascia. You'll see lines of force, and this is the fascia that reacts to long-term stress or force on it. It's a kind of fascia that envelops the muscles. Each muscle sits within a fascial layer or fascial bag, and you'll feel in patients who have chronic tension, you feel and you go, oh, that muscle's got, it's fibrous, fibrosity, but often that's within the fascia, the connective tissue that you're feeling rather than necessarily the muscle, because the body, it's inefficient to maintain a contraction for a long time, so the fascia will then line up and contract along those lines of force in order to be more efficient. So the body, this is the bioenergetic model, where the body is trying to make the best use of its posture and use as little energy to maintain that upright posture as possible. So the deep fascia is quite different to the superficial fascia. It has much more structure, it's much stronger, it also has a role in support when muscles contract, particularly the axial muscles of the spine. One of the things we think of as those muscles just work in isolation. The reason they have a mechanical effect, they have this as work done by Willard, is that you imagine it's almost like a tyre sitting around the outside, and the muscle inside is like the air inside the tyre. And as long as that air is pumped up, then you get, you look at a tyre, it functions really well as long as it's got air in it. But what happens when we get older and we sit for too long is that the muscle gets replaced by fat. So when the muscle contracts, it no longer pushes out on this fascial layer, and so you lose some of the structural integrity and strength in your back. And so then the osseous structures, the ligamentous structures come under more strain. And Frank shows some amazing pictures on this where you can show that if you imagine you have the erector spinae muscle mass, so you've got this sort of cross section here, and normally all of that should be filled by muscle. So when the muscle contracts, it pushes out against this tough layer of fascia there, and that gives it structural integrity, like a balloon, if you like, a long balloon. I think it has a child balloon that you go up at parties, and it has integrity there. But if the muscle only occupies a third of that space, and the rest is just fat, like superficial fascia, when that muscle contracts, it no longer exerts that outward pressure on the muscle, so you lose that support mechanism. And he showed these pictures showing that basically a third of the space in almost all of these 60, 70-year-olds was, there was just no muscle there in terms of around the fascia. He thinks that may be one of the mechanisms for low back pain. So then we come to the abdomen. So you're going to go through lots of layers. We're going to take through of the layers of muscles. So rectus abdominis, external oblique, internal oblique, and transverse abdominis. We come to peritoneum. When we remove the peritoneum, then we get the abdominal contents, and each one of these organs also has fascia around it. And so you can think about this idea of this, connective tissue Russian doll idea, where we go from skin all the way down to the organs, and we should carry it all the way down to the cells, and we should take it all the way down to the organelles of the cells. We take it all the way down to the DNA, ultimately. All of this is surrounded by this connective tissue. And one of the underlying principles of fascial work that we're really discovering now is that one of the reasons why what we do may work, when we just put our hands on someone's back that is hot and contracted, and we apply simple pressure to that, and 5 minutes later the temperature is normalized, the tone has changed, and we just say, well, it's just magic, it's my hands, my feeling hands. So what physiologically is happening there is that there is this mechanical transmission all the way from the skin all the way down to the nucleus of the cell, and which DNA strands get unzipped and which proteins get coded for. We think when we learned about all of the way that proteins get coded for with messenger RNA, and you have this all this code, these triplet codes, which all then correspond to different amino acids. And because it takes us so long to learn it, we think it takes ages in the body, but in fact it's going on all the time, instantly. It's always changing. And so when we feel change in tissues, we feel change in circulation dynamics, we feel change in muscle tone, that's because ultimately the body has responded to those mechanical pressures and altered its function, and that has happened right at the DNA level. And so this process is called mechanotransduction. That's the idea that external pressure on the skin causes a change in the DNA and the way that these proteins are coded. So this mechanotransduction. So it's a really important principle for all manual therapy, is that that's why there are changes physiologically in the body. You know, that it's mechanics as much as anything else. And when Steele talks about the idea of structure and function being interrelated, we now know that that applies to the cell. When a cell changes its shape, it changes its function. And so it will alter how it behaves. And instead of thinking of the cell as just this big sort of membrane around it, and then it's just got a cell nucleus and then all these little organelles dotted around, and it's sort of empty sort of water inside, and the only reason reactions physiologically happen is because it's the kinetic theory of matter, things bumping into one another. That was the old idea, that's certainly what I was taught, but now the reality is that we now know that there's very little empty space inside a cell, and that there's this incredibly complex microarchitecture of connective tissue, which is, we now think, driving much of the physiological processes. So cells alter their function according to whether they're compressed, whether they're stretched, whether they're twisted. They will change how they behave. And that has great implications for what we do. Because, you know, the biochemists have just thought about the biochemical, of course, that they're right in terms of, but what is driving some of those may in fact be the shape. And the reason why this has not been paid attention to, you know, my brother's a molecular physiologist, a molecular biologist. He's sat in labs, you know, trying to figure out, you know, what happens at each step, and they're stopping the process, painstakingly each step, measuring what's there. But in order to measure what's there, they have to spin out all of the connective tissue and get rid of it all, because it's all in the way, getting in the way of what they're trying to measure. So they didn't pay any attention to the underlying architecture that's there, which is in fact driving a lot of these processes. And it's only now that we're beginning to understand that. So that has real implications for us, you know, for health. It's why what we do may have an effect, and one of many reasons, and there's probably far more than we, you know, if we scratch the surface. So the fascia is really important. And we think about the two main fascial compartments within the trunk. We have the thorax, we have the thorax. We always have this double layer mechanism where we have an external and internal layer. So we have that same, it's true with the peritoneum. So if you look at the peritoneum here, this is it's taken a bit of artistic license, but it just demonstrates generally this principle of these separate bags, but that they are interrelated by the function of the diaphragm. And, you know, so, you know, often there was a thought amongst women when they were with childbirth that they thought, well, if I have a caesarean section, then, you know, that's going to reduce my risk of pelvic floor problems and prolapse and all that sort of thing, because no damage is happening to the pelvic floor. But if you make a cut here, you're altering the continuity of that structure. You're still going to have an effect, potentially. So we just need to remember, no matter what the mechanism of delivery, if there is trauma to the peritoneum, it's going, wherever that trauma is, it has the potential to affect things further away from it. So that's just the way we need to think about that. Another 10 minutes. So as we look in here, this is a superior view looking down into the pelvis. So here, to orientate us, we have the bladder, we have the uterus, the fallopian tubes, and the round ligament coming off here. And what you can see here is that it's just one structure. It's one continuous structure overlying each of those things. Okay, so when we talk about the broad ligament out here, it's part of the peritoneum. So we come again round here, we just look at the same thing, we have bladder sweeping over the body of the uterus. We have the round ligaments here, so this is what I was talking about, where they come out laterally to the inguinal ligament and come down anteriorly. We have the fallopian tubes. And we do notice, and it's deliberate in this picture, you can see the part of the ovary, and you can see the obturator nerve that's behind it, you can see part of the ovary, you can actually see the ovary, and there is a little foramen here that allows the there are cases where a woman doesn't have a fallopian tube on one side, but has an egg on the other side, and you think, well, how does conception still take place? In that case, it does still take place. And it was thought for a while that maybe the fallopian tube from one side comes over, and there's mobility, and kind of just makes that connection and sucks up the egg, and that's one mechanism. But another proposed mechanism is that the egg is released into the abdominal cavity and will migrates across and comes to the tube on the other side. So it goes through this little ovale, the little opening there into the abdomen. So that's quite interesting that that's sort of there. The other structures I want you to be aware of are these three ligaments here, which support the bladder. So this is the median umbilical ligament, and then these two on the side are the medial umbilical ligaments, and we will test those later. Okay, same picture really, just showing much the same thing. The point of this picture really is just to show the peritoneal cavity, and everything behind that we call retroperitoneal. So the kidneys sit behind there. Actually, the ascending and descending colon are technically retroperitoneal, but yeah, we won't get into that. And then we'll talk about the idea, but also what's important is to realise is that the pelvic contents are effectively retroperitoneal as well. These organs, the bladder, the uterus, and rectum, all sit outside of this bag. So it means that they're vulnerable potential to congestive issues because they sit outside that structure. If we think about the moving structures in the abdomen, these are things that we test a lot, so these are things we're going to look at later. So we think of the transverse colon. We never know where the transverse colon can be. It can be very low, it can be very high, so we can't know always when we put our hands on the abdomen where it is. But we do know where it attaches, where the transverse mesocolon attaches on the posterior abdominal wall, which would be around the level of L1, L2, which is where the nerve supply comes from. The small intestine hangs off this, the root of the mesentery. So the entire small intestine hangs off this diagonal line here. So this is looking at the posterior abdominal wall, and all of this comes forward, and all of the small intestine sits within this fascial envelope, but it hangs off this structure at the back here. So the root of the mesentery is one of the structures we will test later, and we're looking to see, does it move around this axis here? And it's really important that this moves well, because when we look at another picture which shows all of the vasculature which runs through there, and then the other structure we look at in terms of movement is the sigmoid colon. And again, that sits directly over the sacroiliac joint, so the left sacroiliac joint. So you can see when you picture these attachment points, you can begin to picture the axes of movement that these organs will make. And so we concentrate a lot on these three structures, how they move, because they have a big effect on the vasculature and the circulation. Looking at the pelvic floor, again, one of Richard's pictures, all of this is highlighted in blue, showing the fascia or connective tissue, and we can see a really good access point for the pelvic floor is here. What do we think this is here, in this central bit here? Come over here. This bit here.
Central tendon, the pelvic.
Yeah, it's connected to that, but there's a particular anatomical term that even the doctors will know about. They talk about
Peritoneal body.
not quite perineal body. The perineal body. So the perineal body sits right here, and it's this sort of collection of soft tissue, and you can see that it has direct connection to some of the deeper fascia as well as the superficial. All of it will ultimately connect here. So it's a very useful point at which we can palpate. So it's on the perineum, so it's just, you can assess it just by finding the perineum and applying simple pressure to the perineum. Apply pressure on, pressure off, and just see how does it respond. Do you get how does it feel? And we'll look at that later. But we can see that it has this continuity with all the different layers of fascia here. And again, just to keep us humble, I show this picture just so that when we put our hands on the abdomen, we say, oh, I'm on this organ, I'm on the ascending or descending colon, I can feel this or that. Remember that we are going through lots of layers. So we have our superficial fascia here, we have external, internal oblique, transverse abdominis. So we have these layers, and then we get to the colon. And bear in mind that also has layers around it as well. So when we say we're certain we're on a particular organ, I think we have to have a certain circumsection. I believe we palpate, I believe we can feel what's going on deep to those muscles. I really do think we can get a sense of what's going on there. But we cannot always be absolutely precise, and we need to accept that we're working through these structures and that it's more complex. And this is from Sergio Paoletti. It's a nice little schematic, just showing the interconnectedness of, say, the peritoneum with the fascia of the perineum, and also going up is the endothoracic fascia, the pleura, cranial base. All of these things are all tied together. And I think that's probably a good place to take a break.